Your patient's blood pressure is 86/43. They look pale and tired but not in shock. So, what can you do right here on the floor to stabilize their blood pressure before it drops further? First step, a passive leg raise. It's quick, safe, and tells you if the patient will respond to fluids. When you raise the legs about 30 to 45 degrees, gravity shifts roughly 250 to 300 milliliters of blood from the lower extremities back to the heart. That's like giving a mini fluid bolus without actually infusing anything. To do it correctly, lay the patient flat or slightly reclined. Use the bed's leg raise function or elevate both legs to about 45 degrees. Make sure you avoid bending at the hips, as this can reduce venous return. Now, wait about 1 to 2 minutes, then reassess their blood pressure. If the systolic BP rises by about 10 millimeters mercury or more, or the patient looks more alert, that's a strong sign. They're likely fluid responsive. Next, let's move to crystalloids, your frontline fluid for hypotension on the floor. Most commonly, that's normal saline or lactated ringers. For most adults, you can safely give up to 2 liters of isotonic crystalloid as an initial resuscitation. A smart way to do this is in 500 milliliters increments, reassessing after each bolus. Start with 500 milliliters over 15 to 30 minutes. Then check their blood pressure and listen to their lung sounds. If they're still hypotensive and their lungs are clear, you can repeat this process up to a total of 2 liters while monitoring their urine output and mental status. But why doesn't the effect always last? Well, crystalloids don't stay in the bloodstream for long. Within about 30 to 60 minutes, roughly 2/3 of the fluid leaks out into the interstitial space. This happens because the molecules are small and can easily cross the capillary walls. Only about 1/3 remains in the vascular system, which is why the rise in blood pressure is often temporary. So, when should you reassess? Check the blood pressure about 5 minutes after the bolus is complete, and then again at 15 minutes. If their pressure rises and holds, that's great. If it drops back down quickly, that's your clue that the patient might need vasopressor support or a medication like Midodrine. And that brings us to our next tool, Midodrine. This is an oral alpha-1 agonist that causes controlled vasoconstriction, helping to raise systemic vascular resistance and in turn, blood pressure. It starts working within 30 to 45 minutes, and you'll typically see its peak effect around 1 hour after you give it. Midodrine is often used for patients who are weaning off repressors, those with autonomic dysfunction, or those with recurrent low blood pressure that doesn't require ICU-level care. However, there are important contraindications. Don't give Midodrine if the patient has severe organic heart disease, acute renal failure, urinary retention, or supine hypertension. You should always check both their lying and sitting blood pressures before giving a dose. So, let's recap the step-by-step approach. First, the passive leg raise, a quick test for fluid responsiveness. Second, crystalloids up to 2 liters in divided boluses, reassessing after each one. And third, Midodrine for persistent hypotension when fluids alone don't hold the pressure up. Each of these steps buys you time, helps stabilize your patient, and gives the entire healthcare team clear data on what's working. These aren't just tasks. They're critical clinical decisions that make a real difference at the bedside. So next time you see that blood pressure trending down, think physiology first. If you found this helpful, hit like and subscribe for more bedside-based nursing insights. Thank you for supporting my channel. Take care.